My name is Jack Korb, and this is a review of Psychiatry. Mental illness and humanity exist synchronously. Over time, our understanding of the psyche has evolved tremendously, as has our treatment of those whose social and personal functioning is inhibited. It is estimated that about 30% of Americans will meet the criteria for at least one mental illness at a given time, and nearly half of all Americans will experience a diagnosable mental illness in their lifetime. Although what we may immediately see in our personal lives or through media may present a linear narrative from the era of deplorable psychiatric hospitals to widespread medical treatment availability, history as well as the present is often more complex than we perceive. Dr. Peter Noble recounts the earliest mention of mental illness in a formal way in the late 13th century. This mention exists in a statute that protected the properties of people who were no longer in his right mind in the hands of the monarchy until recovery or death. This act would serve as the only known piece of legislation directed at the care of those with mental illness until the 1700s. There is certainly more speculation about those with mental illness going on before and around this period, but this serves as the first recognition in law. Previous to the 1960s, psychiatric care was centered around inpatient institutions. In 2012, only 6% of care was recorded as inpatient. The amount of people in treatment for mental illness increased to over 81 times that of 1955. From almost 400,000 patients to over 31 million. This massive explosion of mental health treatment can be attributed a great deal to the expansion of social benefits such as Medicaid under John F. Kennedy, which provided better federal funding of those that were disabled or in poverty. Under Kennedy, a great exodus shifted attention away from inpatient care towards the system we see today, outpatient community-centered care. Coverage of psychiatric treatment under Medicare often excluded classic inpatient institutions, but included more modern institutions such as nursing homes and community clinics. Under Kennedy, the goal became integrating those with mental illness into society rather than seeing them removed from the public. It is perhaps the shift away from physical ostracization towards social amalgamation that led to a dramatic decrease in social stigma by increasing proximity and therefore normalization. In 1977, President Jimmy Carter created a Presidential Commission on Mental Health that ultimately did not have significant positive impact, but represented a need for higher awareness and care in respect to mental health. In previous years, mental health care in the U.S. experienced a setback when World War II demonstrated that soldiers could be treated quickly for psychiatric symptoms and returned promptly to duty, leading to the notion that inpatient care was unnecessary or inefficient. Going back to Kennedy's era, emphasis on community clinics and early intervention to prevent chronic recurrence of mental health symptoms put an end to inpatient care facilities of old. One problem with this, however, was the lack of supporting evidence at the time. Many of these patients could function with mere community care or could be treated effectively with outpatient care. The number of psychiatrists in these offices fell sharply as a result of the ambiguity surrounding this new form of care, and the emphasis on addressing social conditions rather than treating patients directly. The reduction of patients in formal care required the need for a fragmented system of care at community centers that only served to disorganize a system that was already undefined and unregulated. This mess caused many severely disabled people who had previously resided in asylums to now have to adjust to homelessness or incarceration without proper care. As governor of Georgia, Jimmy Carter appointed his wife to the Commission of Mental Health Services, for which she knew very little, and emphasized his community centers as being superior to mental hospitals. The focus on mental health rather than mental illness was intended to focus on contextual factors in treating mental illness, but due to its equivocation, caused those with more severe conditions to then have to compete to those with lesser symptoms to find best through mental health for resources made scarce by community clinics taking such a great precedence over inpatient asylums. The creation of a committee for mental health was designed to be extremely diverse with race and sex to address the needs of a wide variety of people. However, the committee failed to include specialists or those who varied in skill or knowledge. Rather, it was made up of general practitioners who focused on broader social problems related to mental health, rather than the empirical data that reflected discrepancy between actual and perceived usefulness of community clinics and exclusively considering social factors in the mental health realm. Focus on such a broad topic as mental health and prevention/awareness stole attention from the pressing matter of severe mental illness that would require more than social action. The question of where social complexes end and physiological needs began was further blurred. The 1960s and 70s were branded as the era of expansion of the realm of mental health into the territory of neglect upon mental illness in a new form. Much of the result of these actions was to the harm of those that were chronically mentally ill, who would not access shelter or other resources outside of homeless shelters or incarceration because community clinics did not have the resources to provide these things to patients. At each point in history, there is one consistency when it comes to the treatment of those with mental illness: misunderstanding. At some points more than others, this also included a great deal of abuse, neglect, and general maltreatment. In the early 1900s, even a facility deemed highly advanced in Caligari, Italy, painted a picture of conditions bleak and torturous. One patient recounted her experience after being admitted at the age of 10, where she was chained in a basement with dozens of others in what can only be described as deplorable conditions. She recalled patients being subjected to leeches, forced vomiting, laxatives, ice baths, and purposeful blistering on the neck. This patient spent 80 years in this hospital. Her initial complaint? A headache. Another patient, Clifford Beers, wrote about his experiences with physical abuse, solitary confinement, and extended periods of time secured in a straitjacket in his famous book, A Mind That Found Itself, an autobiography, which eventually led to the founding of what is now Mental Health America, which strives to erase stigma against mental illness. Many stories such as these exist, and many victims of such practices are still alive today, some of whom suffered greatly from experimental treatments that often had devastating effects. One notable treatment that took off in the early 20th century involved drilling into the skull and disconnecting the frontal lobe from the rest of the brain, the lobotomy. More than 1,000 lobotomies were reported in the UK alone in a single year at the height of its popularity. Only a third of patients reported positive effects from the procedure. However, criticism exists surrounding the quality or quantity of follow-up visits. One of Britain's most notable neurosurgeons recounts the loss of social function and a dramatic increase of apathy among former lobotomy patients. Sociologist Erving Goffman defined stigma as the state of being disqualified from social acceptance. Goffman noted that attitudes change over time, and what inhibits acceptance by others or what disgraces them according to society's standard may shift. For much of the history regarding mental illness, sufferers were often considered pathologically or morally disturbed. Brain autopsies were often considered a valuable tool for assessing mental illness and supported the notion that these conditions reflected a physical defect. A developing field, social psychiatry, put mental illness in the context of the environment rather than exclusively in the hands of the patient. Beginning after 1900, methods of understanding mental illness began to emphasize the context and social environment of a patient rather than exclusively the patients themselves. This led to the eventual practice of conducting home visits with patients as a means to understand the contextual and environmental factors of mental illness in a patient. Another factor leading to stigma against mental illness is the misunderstood relationship between mental illness and criminal behavior. Although the rate of mental illness is higher in those that are incarcerated, mental illness is not a good predictor of violent criminal behavior as is often presumed. Visualizing mental illness predominantly as biological contributes to the notion of an individual being dangerous and unpredictable. These ideas have actually increased since the 1950s, especially considering conditions like anxiety and depression, despite the general public's diminishing, stigmatizing ideas around mental illness as a whole. These ideas have contributed to the growing belief that mandated care of an individual is necessary to reduce the individual's threat to others or themselves. Today is the threat of mass shootings that rings in people's minds when considering the need for care and caution regarding mental health. Historically, mental health issues have been considered under two different lenses, demonological and scientific. No disorder is more prolific than that of hysteria when it comes to women, taking on different names and understanding through history. Generally, this so-called condition is a consequence of believing women to be fragile, easily manipulated, or guilty of some misdeed, whether that be insubordination or failure to carry a child. Much speculation to its origin in an individual stems a great deal from male-dominated medical fields having a fundamental misunderstanding of the female sex, such as with the belief that female madness often stemmed from a lack of a normal sex life or regular sex life, for which the cure was sexual or ritualistic in nature. Hysteria was generally a stand-in for general mental illness symptoms as well as defiant behaviors. The first to use the term hysteria, Hippocrates, like the ancient Egyptians, thought that this condition was the result of the uterus moving throughout the body. During the Middle Ages, a demonological approach to women's mental illness, considering each of them as being bonded with the devil, and that hysteria was a symptom of sorcery or witchcraft, was treated as heresy and often with exorcism. It was not until the 17th century that philosophers and physicians began to theorize hysteria as related to the brain rather than the uterus. However, this theory was not as widespread, and bouts of mass hysteria, such as what is seen in the late 1600s in Salem, would meet a deadly end. Some of what held back the idea that hysteria was linked in some way to the brain was the idea that it would be seen then in both sexes, whereas if it was of the uterus, the disease would only exist in women. Throughout the Victorian age, women were inclined to carry around smelling salts, as it was thought that the odor would keep the uterus from wandering about and thus keep women conscious, illustrating the great impact that Hippocrates carried throughout the time in this regard. Freud brought hysteria into the realm of psychology, and then extended its reach to men. Freud, in setting the stage for the Oedipal complex, described hysteria as a failure in psychosexual development, and therefore utilizing unfulfilled sexual energy and other ways to fill one's needs. People of color historically have a sense of mistrust and an underutilization of mental health and medical services, in part by clinicians' misunderstanding of cultural contexts and perspectives. This mistrust may serve as a large obstacle to obtaining proper care for mental illness. A common theme through the 19th and early 20th centuries was that people of color were biologically inferior to white people, which was supported by white physicians and many medical journals at the time. In 1840, a U.S. Census report made a fictitious claim using fake data that the rates of mental illness in the black community rose the farther north they lived. Also among deliberate acts to control black people in the 19th century was the creation of a mental health disorder called drapetomania, which was expressed by attempting to escape slavery or disobedience towards their masters. Though blatant racism has receded, its effect on medicine and the black community are lasting. A modern issue still affecting people of color is the overdiagnosis of serious and underdiagnosis of less serious mental disorders. For example, compared to overall population samples, there is an overdiagnosis of schizophrenia among people of color, as well as an underdiagnosis of affective disorders. This may be partly due to a lack of cultural awareness, contextual analysis, or clinician bias. Clinicians often have the problem of seeing people of color as inherently different, or that they are more simple, emotionally unstable, or sociopathic by nature, which causes a misinterpretation of behavior, which may in turn increase involuntary admittance, which in turn perpetuates mistrust. Early documents of those with mental illness usually included little more than a name and a diagnosis. President Kennedy's expansion of social benefit to community mental health centers set the stage for a bureaucratic process of documenting, caring for, and funding mental health care like never before. Many programs that followed Kennedy's Community Mental Health Centers Act of 1963 further standardized mental health care on a federal level, requiring the development of a series of other programs and laws for the sake of insurance coverage, medical and therapeutic treatments, patients' rights, formal recording of care and diagnostics, and informed consent, which inevitably streamlined and also complicated the process of receiving care for mental illness. Today, some physicians feel that bureaucratic takeover of the field of mental health has been detrimental to patient care and practices, especially psychiatrist Dr. George Dawson. Dawson expresses frustration with the takeover of facilities by business people and the taking of practicing decisions from psychiatrists themselves. He states the role politics have in care as the result of this streamlining process, and that practicing in this field is now modeled on productivity and care designed to optimize business, in which going against the decisions of business administration can result in punishment. Dr. Dawson states that the business model of today does not resemble the care he gave patients 30 years ago. He also explains that clinics were run by physicians and those with knowledge and experience when it came to treating patients who were often treated as a charity if payment could not be made for the sake of their mental health. The transformation of the mental health care system has reduced the quality of care because there is not enough funding allocated to properly pay reviewers of facilities, especially those that are Medicare funded. Reviewers were in charge of looking into situations where a patient may have been placed in an inappropriate medication, held too long, not holding long enough, or prescribing unnecessary tests or procedures. Dr. Dawson explains that reviews are often now conducted for utilization rather than the quality of care, which, although good for business, is bad for patients and physicians alike. Business takeover led to a great deal of problems regarding documentation, billing, and coding, which are often subjective according to the business administration, and practices could be fined substantially with backing of the federal government if anything was slightly out of place, leading to the need for new departments dedicated to keeping paperwork and billing in line. Pharmaceutical companies working in line with managed care often price gouge for low-dose medications, which results in an overload of patients needing to constantly call their doctors for help getting extra medications that they have run out of before being able to get more, which creates a great deal of extra work for physicians trying to keep up with the ordinary care made difficult by business managers. Refusal to hire more staff also results in having too many patients for staff to handle, which negatively affects the quality of care to patients and the satisfaction of physicians. In general, care of those with mental illnesses lies directly in the hands of those with no knowledge or experience of care. They are merely faceless entities making subjective decisions and demanding payment according to made-up prices. The workings of bureaucracy in the field of mental health does nothing to inspire empathy, goal attainment, recovery, or positive effect for patients, but rather the focus is on profit. Changes that have taken place and the progress made, for better or for worse, have been hard fought and at the expense of many lives in the process. Elizabeth Cochran Seaman, more famously known as Nellie Bly, went undercover for 10 days in the New York City Lunatic Asylum in 1887, then published a scathing report on the conditions that proved so devastating to the city that an extra $1 million were allotted to the asylum annually to rid the asylum of its abuse. Overcrowding with insufficient and inattentive medical staff, insensitivity to immigrants, abusive treatments such as cold baths and confinement in small, dank, pest-infested rooms. After thorough investigation, many of the conditions improved, which included better meals and the replacement of the abusive staff. Her experience gained global attention and shed light on the horrid conditions inside many of these like asylums. One study in Australia examines the role of the First World War in changing how mental illness was both viewed and treated. Before the war, it was common for those who did not appear normal or social outcasts that were treated with disgust and distrust. Soldiers returning from war were suffering from an epidemic of what is referred to as shell shock, a condition not previously noted or understood. These men, who were generally highly regarded and often considered heroes, were suffering from something akin to a mental illness at a substantial rate. Clinicians and many of the public were forced to reevaluate their stigma against mental health and the notions that those with mental illness were defective physically or morally. As understanding progressed, the idea that mental illness had a poor prognosis began to fall out of favor. Rather, the idea of recovery and improvement became a focus and a target for care instead of simply separating the mentally ill from society. Today, the world of psychiatric treatment is quite different clinically and culturally than decades and centuries past. Some consistent factors remain, however, with access to treatment, stigma, and policy in need of evaluation. We see an increase in the need for treatment of mental illness, which is expected to jump 2% globally over the next few years. Although strides have been made in many regions, 28% of countries specify no budget for these services, and an additional 36% only set aside less than 1% of their yearly health budget for mental health treatment. In terms of policy, only 60% of countries have formal policies regarding psychiatric treatment. It appears that a universal issue, however, despite a country's legislation or budgeting, treatment is often financially inaccessible to those with less means, and there is often a gap in the prevalence or quality of care between high and low-income patients. Many low-income families are made to take on the strenuous care that may come with looking after someone with a mental illness, leading to significant financial expenditure, exhaustion, depression, anxiety, and perhaps worsened mental health. The argument can be made that inpatient care, despite its own flaws, could ease many troubles that family caregivers may face trying to look after their loved ones. In countries with a high negative perception of mental illness, such as India and parts of Africa, people often turn to traditional healers for care as to avoid labeling and stigmatization. This culture of stigmatization also leads families themselves who have negative perceptions of mental illness and treatment to fail to seek out care out of the lack of knowledge about these conditions. A lack of understanding about mental illness means that a family will often fail to provide adequate care for a loved one with a psychiatric condition. Many countries still prioritize institutions which are often overcrowded and inadequate for rehabilitation or individualized care. These institutions often see mental health care in terms of biomedical factors rather than social factors, which promotes the overuse of pharmacological treatment. Much doubt still exists about the effectiveness of treatment regarding mental illness in a clinical setting. A survey of international medical students, interns, and physicians found that only 5 to 10% of those surveyed chose a career in psychiatry and that it was generally rated poorly by students. Among perceived negative factors of a career in psychiatry were as follows: lack of scientific foundation, perceived low status, prestige, and financial reward of psychiatry, psychiatrists as poor role models, difficulty with the population and treatment, depressing and frustrating perception of psychiatry, and loss of opportunity to use clinical skills. Stigma, especially regarding poor prognosis, needs to be addressed. An understanding of historical factors and stigmatization is necessary to combat needless stereotypes and mistreatment. Collaboration between patient and practitioner, positive attitudes, and a drive towards recovery are instrumental to modern mental health care. A large consideration needs to be made about the extent of care that needs to be community-based or institutionally based. We know that community care can often provide too little for those with chronic or severe conditions, but institutions are far removed from society and are often unable to provide individualized care. Funding of either system exclusively will likely not be sufficient for the overall care of those with mental illness or other mental health conditions in the long term. Many of the problems in mental health care historically have stemmed from misinformation, pseudoscience, the lack of representation from diverse groups, convenience, and stigma. Today these problems are alive, but they take new forms such as bias, stereotyping, and the bureaucratic system in place to standardize the process of receiving care. This complex issue is ever-changing and increasingly relevant, but with a multi-dimensional understanding and input from those in care and those who treat alike, significant progress could be made untangling this overwhelmingly vast web of effective and ineffective care techniques. The following is the list of works cited. My name is Jack Korb, and thank you for your time.